Hello everyone, I am Dr. Dharmesh Solanki, cardiologist from Wockhardt Hospital, Rajkot, and today I am going to talk in next 10 minutes about the oral semaglutides, CVrisk factors and cardiovascular prospectus. So these are my financial disclosure. So why cardiologist is in between these diabetic drugs? And this is the answer. If you look at the lifespan, after the age of 60 in a non-diabetic patients, which we call nearly in India is around 75 years. But when the patient becomes diabetic, the lifespan reduces by 6 years. And when there is an associated cardiovascular risk factor or a cardiovascular disease, the mortality increases or lifespan reduces by 12 years. And that is why we cardiologists are here in between the diabetes and the patients. If I wanted to explain you the basics of the macrovascular, we call macrovascular and microvascular complication of diabetes, and cardiovascular complications are a macrovascular complication. It starts with the central obesity, then it results in insulin resistance. This results in pro-inflammations. There is an increase in the lipids, there is an increase in the blood pressure, and there is an increase in the glucose. Then there are non-modifiable risk factors associated like genetic predisposition, age. As the age advances, the prevalence of diabetes is increases, and external risk factors like smoking. And these all complex of puzzles results in type 2 diabetes or a macrovascular complication of diabetes. And just merely controlling the sugar will not help in preventing or treating these macrovascular complications of diabetes. So one need to remember that we need to address all these starting from obesity, insulin resistance, inflammation, hypertension, and dyslipidemia as well. So today's topic is on the GLP. You all know the mechanism of actions and I am not going into the details of that. GLP-1 analog has a proven cardiovascular benefits. It is highly effectively reducing HbA1c, and not only HbA1c, it reduces the weight, inflammatory markers, it reduces the LDL sugar, it reduces the blood pressure, and hence it results in cardiovascular benefits. Let us see into the clinical prospectus trial, what the trial is to say. The Pioneer program is with the oral semaglutides, and there are Pioneer 1 to 10 trials, and these trials has been conducted against its active competitor. Means active competitor means it has been compared against the SGLT2, DPP, subcutaneous GLP, metformin, sulfonylurea, pioglitazone, insulin, and so on and so forth. So it gives you an extensive idea that how these drugs has been placed against this active competitor in terms of reduction in weight, reduction in HbA1c, and cardiovascular benefit. Particularly Pioneer 6 study, which is a CV safety data, is also proved relative more reduction in weight at the end of 1 year as compared to the empagliflozin. Not only weight reduction, it reduces the weight circumference also, which is again a very important cardiovascular risk factor marker. So waist to hip ratio or waist circumference is reduces more by 45% as compared to empagliflozin, or absolute reduction in nearly 4.7 centimeter as compared to the empagliflozin, which is very significant in a patients with type 2 diabetes mellitus. Not only it reduces the weight, it results in reduction in the blood pressure. It reduces the systolic blood pressure by 5 millimeter of mercury. If you look at the various data, that reduction in 10 millimeter of mercury in a type 2 diabetic patients reduces the cardiovascular and other complications of diabetes, particularly any complication related to diabetes reduces by 11%, myocardial infarction by 11%, death resulting in 16% or 10% in the microvascular complication. So it reduces the blood pressure. Again, going to the other aspect of the pleiotropic effects, it reduces the hsCRP, which is a systemic inflammatory markers. So if you look in comparison with the placebo, it reduces statistically significant at the half-year interval, and at the 1 year interval, the empagliflozin versus oral semaglutides there is a 37% reduction in HSCRP as compared to the empagliflozin, which is statistically significant. So it reduces the inflammation as well. And if you look at the coronary interventions trial, so various trials and the data has proposed that reduction in 4 millimeter of mercury reduces 12.5% prevalence of coronary artery disease, which in our patients reduces 5 millimeter of mercury. 1 millimole reduction in LDL results in 8.2, and 0.9% reduction in HbA1c results in 2.9% reduction with an established coronary artery disease whose age is more than 60, or patients who has a one cardiovascular risk factor with the age more than 60. Type 2 diabetes mellitus, very significantly high follow-up of almost 99.7%. And if you, though it has failed to prove on the superiority, but there is a non-inferiority statistically significant reduction. If you look at the each hard endpoint, the MACE is statistically significant, CV death is statistically significant, all-cause mortality is statistically significant. So these all overall favors in a semaglutide oral preparation as compared to the placebo. Now, this semaglutide oral from Pioneer 6 has been compared with the Sustain 6. This Sustain 6 is a subcutaneous injection of semaglutide. It is not available currently in India. It is once in a week dose to be given subcutaneously, and they have proven the superiority as compared to the placebo. And if you compare both the data of Sustain 6 and Pioneer 6, which is hand in hand similar, and when both are being combinedly joined, it further reduces the risk of cardiovascular death, MI and stroke by 24%, which is a superior reduction as compared to the placebo. So where we put SGLT2 and where we put GLP, GLP-1 can be given in any patients of diabetes irrespective of their starting age. Any risk factor, associated risk factor like obesity, hypertension, dyslipidemia, GLP-1 will be the drug of choice. When patient has established coronary atherosclerotic coronary artery disease, it is type 1A indication for patients with the diabetes, while SGLT2 has a type 1AB indication in patients with the heart failure. So coming to again where I have started, let us understand this puzzle again, whether GLP-1 has addressed all this. It has addressed obesity, it has addressed insulin resistance, it has addressed inflammation, it has addressed hypertension, it has addressed dyslipidemia, and most importantly, it has addressed the glucose. So way go forward to prevent the cardiovascular complication if the one drug which has a pleiotropic effects in a patients with a type 2 diabetes mellitus is GLP-1. And I want to give a one-line message is GLP-1 is to be started as soon as possible in a patients with type 2 diabetes mellitus, to be up titrated to the maximum tolerated dose, and to be considered in each and every patient, whether patient has established coronary artery disease or at a high risk of patients, a high risk of developing coronary artery disease, should be given GLP-1. Thank you for your patience listening.